So safety first, excellent talk on most neglected part of intervention, radiation hazard. So now I will invite Dr. Farhan Tayyab. He is Major General at Kulsum International. And you all know the selection of appropriate coronary guide wires is very relevant to any procedure for its efficacy and safety. So Farhan Tayyab.
I have no conflict of interest. So coronary guide wires are used to track through the vessel, access the lesion, cross it atraumatically, steer into away from the side branches for device delivery, and optimal wire selection can make the difference between procedural success and failure. And coronary guide wire is considered to be the master key to all locks. The basic guide wire there are three main components. One is the central core. Second is the outer coverings, and third is the flexible distal tip. Sometimes the core travels to the tip that is called as core to tip design. Otherwise, there is a shaping ribbon at the end of the vessel, the business end of the wire. The wires can be divided into kind of three groups with their, anything which is less than 1 gram, and the tips network is called as soft wire. The examples are like BMW, run through, Sion wire from Asahi. And intermediate tip can be, say, from with tip load of 1 to 4 grams, which are examples are Pilot 50 and 150 Gaia first. And then there are hard or stiffer wires. The best examples are Miracle 6, 9, and Conquest Pro. For CTO lesions, the single tip, or they can be double tip. Or for non-CTO lesion, generally a 45-degree bend, which is known as the J bend, is the best curve. So the basic wire handling tips include that a wire should be advanced gently and should pass smoothly. Withdrawal and reorientation is required if there is buckling. It should not be forcefully jammed because it can disrupt the block and cause acute vessel closure. Repeated counter and clockwise rotations help in smooth progression. Generally, do not retire the wire more than 360 degrees continuously. And one should place the wire in the vessel as distally as possible, but should not, in general, hit the end of the wire. So this is an example of a lesion. It's a tight left main ostial lesion. It's a short lesion. And the wire we used to cross was the BMW wire. And you can see this cross, and we did a left main to LED stenting. And BMW, this shows the detailed structure of the BMW wire. Now, this is another example of a patient with acute coronary syndrome. There is a thrombus in mid RCA. And the wire used to cross this type of lesion was, in this case, Sion from Asahi. It's a tip load of 0.7 grams. It has got a go-to tip design. It provides medium support. And that was the end result. This is the basic structure of the Sion wire. Now, these wires, which are, like BMW, Sion, run through, these are called as workhorse wires. And these are suitable for crossing type A and B lesions and some type C lesions. They are very useful for primary PCI, to cross acute stent thrombosis, for bifurcation lesions, recent occlusions. They can be used as buddy wires, cutting wires, and anchor wires. These wires are generally not useful for crossing chronic total occlusions. This is an example of an RCA with extreme tortuosity. You can say initially this was engaged with a hockey stick catheter. Then we changed to an ambulance 2 catheter. Initially we used a run-through wire to cross the lesion. But then as we pushed the balloon, everything got thrown back. So we were able to recross, and this time we used a buddy wire, which in this case was a Whisper Extra Sport wire from Abbott Vascular. It has got a core-to-tip design with 1.3 grams as a tip load. So the procedure was completed, and buddy wire was removed after placement of the stent. So other wires which are used as a sport wires include high torque balance, heavyweight, Ironman, and Grand Slam from Asahi. Now coming to bifurcation wire lesion tips, one should try and wire the most difficult lesion first. One should try and wire the most angular lateral lesion first. And then one should avoid giving the wire more than 180-degree rotations to avoid wire entanglement. And one should not remove the side branch before the side branch has been recrossed after stenting. In case of wire wrap, one should withdraw the wire, which is more easy to rewire. Now, advantage of keeping a wire in the side branch include it keeps it open, makes recrossing easy by making the angle more favorable, serves as a marker in case of severe reduction of blood flow. If recrossing is not possible, a small balloon can always be passed sub-stent to open and establish flow in the side branch, which can make the wire recrossing easier. So this is an example of LED diagonal bifurcation with the tap technique. We use 2 run-through wires for this. Then we first of cross both lesions with the wires, then dilate and stent the main vessel. Then you recross, open up, and then stent and finish off with the kissing balloon. This is an LED tap bifurcation example. Run-through wire is the front-run wire from Terumo. It's particularly used for multiple interventions. One wire can do all the 3 vessels or 3 lesions. It provides good conformability and support and trackability. It's got a dual core design. Shaft is stainless steel and distal core, and shaping ribbon are of nitinol alloy. Distal 1 centimeter is shapeable. Now, for side branch access during bifurcation lesions, wiring and rewiring, the key point is a key point for bifurcation PCI. The presence of severe calcification, severe stenosis, and distribution of stenosis, tortuosity, angulation, and less than TME throw wire can cause problems for crossing the wire. The techniques used are antegrade wire technique, pullback, reverse wire. Sometimes you have to use assisted catheter like microcatheter or venture catheter. At times you may have to pre-dilate or may have to occlude the main vessel to get into the side branch. There is a gel balloon technique in very high risk branches where occlusion cannot be afforded. You can place a balloon in the side branch and then inflate. For rewiring, pullback technique is preferred after doing the port. Workhorse wires are recommended in bifurcation lesions. Hydrophilic wires shorten the time but increase the chances of subintimal wiring. And one can always use a rescue balloon over the sub-stent wire. And for subtotal, total occlusions and chronic total occlusions, the technique used is sliding, drilling, and penetration. There are 3 steps of crossing a CTO lesion, which include crossing the proximal cap, then navigating through the occlusion, and entry into the distal lumen. And the process may involve use of multiple wires, like from soft wire to an intermediate stiffness wire to a polymer wire to a very stiff wire and back to a soft wire. This process is known as escalation and de-escalation. Now for CTO antegrade, we have to decide which way to go, antegrade or retrograde, or is there is presence of microchannels, or is the distal vessel lesion clear, course clear or not. If we start with for microchannel, we can start with a Fielder XT wire or maybe a Gaia second wire if the vessel course is clear. Otherwise, you should use a stiff polymer jacket wire, which is Pilot 200. Now, this is an example of a subtotal RCA. In this, we tried to cross with the Sion wire, but then we couldn't cross it. We had used a Pilot 50 wire to cross the lesion. Again, it's a wire with a plastic tip. The alternative wire would have been a Fielder FC. This is an RCA with bridging collaterals. You can see very, very tight occlusion. But there was a microchannel visible for microchannel crossing, but the wire is Fielder XT. And that's the final result later on. So this for microchannels, Fielder XT is the wire. Now this is a lesion where we could see the course visible. We tried to cross with the Fielder XT wire to microchannel, but we couldn't do. So we had to use a Gaia second. We have lost the. Okay, thank you. So this is the use of Gaia second wire. So that was the final result. So these guidewire wires are very effective for crossing total occlusions and for retrograde wire crossing as well, and for reverse cart. This was an occluded LED. The distal vessel course was not very clear. We couldn't see a microchannel. We used a pilot 200 wire, which is a hydrophilic wire with a tip load of 3.9 grams. And we confirmed with giving a contralateral injection that was the final result. So this is the pilot 200 wire, also used to knuckle. So in case of CTOs, we have to see that if there is a clear proximal cap and good distal target, lesion less than 20 meters, you can go antegrade, escalation and de-escalation. And otherwise, you have to attempt retrograde. So this is an example of a retrograde RCA case. You can see there is a very long occlusion. There is, side branch. So this is there are multiple wires here. One wire used an anchor wire. Second wire has been used to cross antegradally, couldn't succeed. Then there is, you can see a wire in the main donor vessel for retrograde, and then there's a microcatheter. You can see the wire crossing and then followed by microcatheter. Then there was a reverse cart was done. And that was the final result. And for externalization, RG3 is used. So these are different wires for crossing into the collateral channels. SOHO wire is used for epicardial channels. So in this particular patient, 18 wires were used. You can see there's a very long, laborious case. Now, one should try and place the wire as distally as possible for better support. Should not let the wire move forward or get pulled once across the lesion. One should try and keep the wire clean always. If there is a loop formation in the ascending aorta, at times it happens, you should pull the guide cath back and then push forward, pulling the wire at the same time. And avoid gearing the wire in calcific lesions at very high pressures. Wire-induced perforations can be managed conservatively. And in the words of Charles Daughter and Melvin Judkins, the guide wire is passed through the atheromatous block without going through the wall, maybe more by application of judgment than by force. It's important for the operator to focus on selected set of wires rather than trying to use all the wires that are on the market at the same time. Thank you very much.